Hello and welcome. My name is Ann Massey, and this presentation is part of the pre-workshop module that we are preparing in advance of the workshop that's being sponsored at the Nell Hudson Woodruff School of Nursing at Emory University for nurses at the CDC who will be volunteering at the VA. I've designed this to be a review of some basic kinetic principles and most importantly metabolism, as you might guess by the title. So we'll be talking at the workshop on the 27th about common treatment guidelines for commonly encountered disorders among VA patients, including mental health, cardiovascular disorders, and diabetes. This means that many of the patients that you may be seeing at the VA will be exposed to polypharmacy or multiple drugs to treat multiple conditions. So it would be important to understand how these can produce drug-drug interactions and impact your patient's response, and also how this could impact your care. So our kind of overview is a place to start. Now moving on, I've included here learning objectives, and as we've said before, the focus here is really going to be on metabolism because metabolism is a common place to encounter drug-drug interactions, but also drug-food interactions. And so we're going to be looking at CYP450 enzymes in particular, and we're going to be looking a little bit at genetic polymorphisms that also lead to changes in patient response to a drug because of changes in metabolism. All right, now, so let's get on. This particular slide is a representation of what happens to a drug once it has been taken into the body. So you can see here, I'll just kind of lead you through this. The drug is administered over here. After it's been administered into the body, it has to be released from its formulation. As it's released, it's going to be absorbed, and that absorption is going to be the movement of the drug from the site of administration into the plasma. And then from the plasma, the drug is further going to move throughout the body to different areas. So it could move to fat, it could move to bone, it could move to muscle, it could move to the body water, some other compartment in the body. Upon distribution, it can interact with receptors, it can unbind from receptors, it can go back to the plasma, it can be biotransformed, which is a fancy word for metabolism, and ultimately it can be excreted. So this represents our overall picture of what's happening during pharmacokinetics, or how the drug travels throughout the body. So we've got absorption, distribution, or the movement from the drug after it's been absorbed from the plasma to different tissue areas in the body, metabolism, and excretion, or removal from the body. Now, these kinetic factors will impact your patient's response to drugs, and I'm sure I'm not telling you anything that you don't already intuitively know. For example, if your patient has renal impairment, and it's very common to assess patients' renal function before beginning a new drug. If your patient has renal impairment, then you might expect excretion to be impaired. If excretion is impaired, then you might expect to see increase in drug concentrations in the plasma and in other tissues throughout the body. And this in turn could lead to an exaggerated or an enhanced patient response or even toxicity. And toxicity is particularly a problem where you have a patient who's being given a drug where the toxic concentration is very close to the therapeutic concentration. So similarly, our pharmacokinetic parameters here also provide targets for drug interactions. So in patients that are taking a drug where they have a good response, and then maybe they need to have a second drug added to treat either the same condition or a different condition, and it may impair the absorption, the distribution, the metabolism, or the excretion of the first drug, and you may see a change in their response. Okay. Now, clinical drug monitoring, what's important? And we have here absorption, clearance, volume of distribution, and half-life. So absorption of the drug, and we said initially that this is the movement of the drug from the site of administration into the plasma. This determines how much goes into the body. There are lots of things that can change absorption, and we typically think about these things as being related to orally absorbed medications. So antacids or different foods, for example, can alter absorption of a drug. Clearance of a drug can be impacted, as we said in the previous slide, when you have kidney failure, even sometimes also liver disease, and or if you have impaired blood flow to organs, because clearance is going to be a function of blood flow to those organs, particularly, as we said, the kidney. Volume of distribution. This is a theoretical volume in which the drug is dissolved in the body. And this can be impacted. The volume of distribution changes with age. So the changes in the body composition that result with age, where you have different ratios of fat or lean mass and body water due to different concentrations of protein, all of these are going to serve to change the volume of distribution, and this in turn changes the way the drug moves throughout the body. And half-life, this is a measure of the amount of time that it takes for one half of the drug to be eliminated from the body. This also is going to be dependent in part on volume of distribution. So as volume of distribution changes, half-life can also be impacted there as well. If the half-life increases, this means that it takes longer for drug to be eliminated from the body. This means that the drug is present in your patient's body for a longer period of time, and this in turn means that they are more likely to be exposed to higher drug concentrations or even toxic concentrations. The maximum effect, this is a pharmacodynamic parameter or a pharmacodynamic principle. And this really is going to be due to the biological limits of tissues and cells. So eventually you're going to get to a place where it doesn't matter how much more drug you give, the response is going to be maxed out, or you'll see a maximum level of response. Clinically, you need to recognize this because you don't want to continue to increase the dose of a drug in a patient where you are not going to see an improvement in response. This exposes your patient to potential risk without any possibility of benefit. And furthermore, by understanding the maximum effect and dosing appropriately, you limit the possibility that your patient will be exposed to toxicity. And sensitivity. This also is dynamic, and this can be related to changes in physiology or changes due to drug antagonism, something that changes the patient's response to a drug. So you may see this in a patient that's been taking a medication for a long period of time, and perhaps the effectiveness of that drug wears off as the receptors change their sensitivity. Now, as we said, we're mostly going to focus on metabolism, so let's review what metabolism is. During metabolism, drugs are modified or changed or biotransformed by chemical action of enzymes in cells. Usually, metabolism results in a more water-soluble compound that's being produced, and this is so that it can be more easily eliminated by the kidney in the urine. When the drug metabolite is produced that does not have an active effect, or that does not have the same effect as the parent compound, this means that the drug action is terminated here. So right away, you should be able to see that patient response is going to be very dependent on metabolism. If metabolism is enhanced in a process that produces inactive metabolites, you would expect drug action to be decreased and patient response to be decreased likewise. However, if we see the opposite, if metabolism is slowed, or if the metabolism that is produced also has the same activity as the parent compound, you might expect that drug action and patient response would be enhanced. Let me give you a clinical example of this. Benzodiazepines are a class of compounds that are used very frequently in the treatment of anxiety disorders. Benzodiazepines undergo metabolic reactions that produce metabolites that have activities to reduce anxiety that are similar to that of the parent compound. Those compounds that have active metabolites tend to have a longer duration of action because the metabolites are also active. And that would be something that you would need to keep in mind as you were finding an appropriate dose for your patient. Furthermore, if your patient is older, they've had changes in their physiology and in their body composition, this means that that can further alter those metabolites or the activity of those metabolites. And so that also has to be taken into account. Okay. Now, this is a schematic that I actually like a lot, and it just kind of gives you an idea of what happens during metabolism. So we have over here, we're going to be administering some drug over here. The drug is going to be traveling into the body. We're going to be undergoing metabolism and then elimination. And so what we've been talking about here is that metabolism involves changing these drugs from the parent compound to something that can be eliminated. Very often, we see that metabolism involves multiple chemical steps to change the character of the parent compound in a stepwise fashion. So if we look here, we've got phase 1 reactions here that then further undergo phase 2 reactions here, which can then be eliminated. Phase 2 reactions often involve conjugation, or the adding of another substituent to the parent molecule to make it more likely to be eliminated, and I'll show you some examples of this later on. Phase 1 can encompass a variety of chemical reactions, for example, hydroxylation or demethylation, and we'll show you some examples there. Now, sometimes here, if we look at this situation, we see that we administer a drug and metabolism produces a metabolite, an intermediate, that has modified activity, which can then be conjugated and eliminated, or a phase 1 reaction may actually produce an inactive metabolite. So in a case where your metabolite is active, you may continue to have drug activity. But in the case where your metabolite is inactive, this terminates drug activity. And both of these can be conjugated and then eliminated. Our third scenario here at the bottom involves a drug that actually does not undergo any metabolism and is eliminated just as is. And there are some situations or some drugs that are eliminated without any metabolism. Let's see some of this in action. Okay, this is an example. This is ethinyl estradiol here. And the arrow is pointing to this region of the molecule here. When we undergo phase 1 reactions, we see that we are going to produce a hydroxyl group. We're going to add a hydroxyl group to this molecule right here. This would be an example of a hydroxylation reaction here. The oxygen and the hydroxyl group here makes this compound more polar. Another example here of a phase 1 reaction would be the demethylation of imipramine. This structure here is imipramine, which is a tricyclic antidepressant. It undergoes a phase 1 reaction where we lose a methyl group here and we result in a compound that is changed here, that has been demethylated at this nitrogen. Furthermore, this molecule undergoes a second demethylation reaction to produce the functional group that you see here. These are both phase 1 reactions that are happening here. Now, what I want to say to you is that imipramine has activity, and this compound also, the desmethyl imipramine, is likewise an active metabolite. So the antidepressant effects come from the imipramine and the activity of the metabolite here as well. And this is clinically important. And the desmethyl imipramine actually is available as a distinct agent to treat depression. Now, an example of glucuronidation. This is an example of the chemical reactions that occur to produce glucuronide or glucuronide metabolites. And this involves a series of complicated reactions that start with glucose. And our glucuronide metabolite here actually has this large polar glucose-looking molecule that's attached to it. And our substance right here, this would be our parent drug compound. Now, the purpose of this conjugation reaction, as you might guess, is to add this very polar substituent to make the molecule more likely to be eliminated in the urine by the kidney. And so one way that you can think of phase 1 reactions is that they add a handle that the phase 2 reactions can stick something polar onto that promotes the elimination of those drugs. Many functional groups can form glucuronide conjugates, so it's used in a variety of substances, and in fact glucuronidation is the most important phase 2 reaction as well. So this brings me to the end of our overview of metabolism here. Stay tuned for another short video clip to talk about the next phase, which would be CYP450 enzymes.